Today we're going to talk about iontophoresis, and I just want you to know that these slides are adapted from previous presenters of this lecture. So this is not original information by any means. I just want to give credit where credit is due. So to review the objectives, we want you to understand bioelectric mechanisms of iontophoresis, describe methods of delivery and application, utilize the appropriate medication for specific conditions, analyze the potential side effects of iontophoresis, determine the efficacy of iontophoresis as found in the literature, and appreciate the capabilities of electrical stimulation combined with medicine. So what is iontophoresis? It's the use of direct current to move ions transcutaneously into target tissues. Current and ions enter the skin through pores and sweat glands. The core principle behind this treatment is that like charges repel and opposites attract. So we'll go through a few definitions. An ion is an atom that has lost or gained electrons, resulting in a net positive or a net negative charge. The definition of phoresis is, there's a number of them. It had a lot of definitions when I looked it up, but the one that I found said that I liked was being carried, and I thought that kind of represented what iontophoresis does pretty well. You could also say that ions are transferred, moved, or transported. For our purposes, we are using it in relation to movement by an electrical current, but it really is a more broad concept than that in terms of phoresis. You may have heard the term phonophoresis in relation to ultrasound. I don't want to confuse you with it. It's not something you need to know, but it is a term that you may hear when you're out in the clinic. It's no longer used because it's really been determined to not be effective, and just the outcomes of the research are poor with it. But you may hear it, so just wanted to know about that. The cathode is your negatively charged electrode. The anode is your positive charged electrode. That's kind of review from Becky's first lecture, but they do play a big role in this. A couple of other terms that we need to define. The active electrode is the electrode containing the medicinal ion. It's also known as the treatment electrode or the delivery electrode. I typically say active electrode. It's important to know that it's not charge dependent, and what I mean by that is the cathode or the anode could be the active electrode. It depends on the charge of your medication. So if you're choosing to use a positively charged ion, the positive electrode will be the active electrode. If you're choosing to use a negative charged ion, your negative electrode is going to be your active electrode. And then there's your dispersive electrode, which is basically the other electrode. It can be also termed the inactive or the reference electrode. Then I quickly wanted to review direct current again. We've gone over this a couple of times as well, but review is always good. Direct current must be continuous throughout the treatment time. It must be a unidirectional current, also known as monopolar. It can be positive or it can be negative. Because of the continuous monopolar current, the charged solution is ionized, which is and ionization is the dissociation of a solution into the simple ions. Alternating current and high volt pulse current are not able to cause ionization. It has to be direct current because it occurs over the time of the treatment, and so therefore continuous current is needed. It cannot switch directions, so it can't be an alternating type of current because of the core principle that like charges repel. So you want to be constantly, throughout the treatment, delivering that medication. In order for iontophoresis to work, the medication must be charged. Ionization is necessary, and that occurs when, again, a soluble compound dissociates into ions. At the tissue level, and that's what this example is, and this is from your book, at the tissue level, when a direct current is introduced to the skin, extracellular ionization of sodium chloride and water occurs, resulting in a flow of charges of the charged sodium and the charged chloride. We'll go into this more in detail as the lecture progresses. There are three primary concepts that need to be understood in order to know what is happening when you apply iontophoresis to your patient. The first one is electromigration. Like charges repel, opposite charges attract. It's that core principle. So negative charged ions are on an electrode attached to the cathode. Positive charged ions are on an electrode attached to the anode. And the charged ions are repelled into the skin. The second principle is electroporation. There's an increase in porosity of the superficial skin in response to E-stim. In other words, the pores in the skin open up to allow medication to move through the skin more efficiently. Skin is typically hydrophobic in nature and acts as a barrier to the ions, so the E-stim is used to cause a temporary increase in the porosity, which allows for ions to more easily penetrate the tissues. From what I've read, the mechanisms of this are unknown, but it is known that E-stim alters cell organization and skin function. And then finally, there's electroosmosis. It can also be termed ionohydrokinesis. That's a mouthful. What happens with this is there is a volume flow or a bulk movement of solute in response to an electrical field. It's not a simple diffusion, which is due to concentration gradients, but instead our skin maintains a negative charge. So the positive ions from an anode will flow easier into the skin because of the net negative charge. But the negative ions under the cathode have to push against the negative net charge of the skin. This is represented here under the 2 bullet points where the positive ions from the anode can float on this stream of positive ions that are moving in the skin to the negative charged skin. But the negative ions from the cathode are kind of swimming upstream in a sense because they have to go against that flow of the negative. They have to go against the negative charged skin. And so there's more, it's a more intense, often more uncomfortable sensation under that cathode because of that. The patient will have more comfort with the positive charged ions rather than the negative. We can talk about that more at lab if you guys have questions on that. So this is another way to look at it. Medication is absorbed through the skin by simple diffusion. It's driven by a diffusion gradient from a high concentration to low concentration of ions. And the direct current adds a push to get that medication moving through the skin into that area to be treated. Patient-friendly way to describe this, and I kind of like this picture because it makes sense, is that a way to say that is, I'm going to put this medicated patch on your skin so that the medication can be absorbed to the area we want to treat. Because the medication has a charge, I can use a small battery with a very low charge to give the medication a push through your skin in order to make the absorption of that medication more effective. So let's get to the application. This is your decision-making process, and here's what you need to consider. The two key areas are the polarity of the medication you're going to use and the best way to get good conductivity. Additional decisions include what type of electrode you're going to use, how you're going to place the electrodes, the method of application or the way you are going to deliver the current, and the dosage you will use. And we're going to talk about each one of these. The first key consideration is polarity. This page is out of your textbook on page 319. It lists the name of the medication, what it is used for, and its polarity. The most common, and you see that flagged there, is dexamethasone. And this is used for inflammation, and it is negatively charged. But as you see on the chart, there's a number of different medications, both positive and negative, that you need to know because potentially you could receive orders for any one of those medications. You'll see at the bottom for hyperhidrosis, which is excessive sweating on the palms or on the feet or in the axilla, there's an alternating polarity technique that you can use, and it uses basic tap water to address that. So going back to dexamethasone is the most common medication you'll use. It's important to know in Minnesota and the scope of practice, your patient will need a physician's order for the medication. It is outside our scope of practice to counsel or prescribe medication use to a patient. But you may need to talk with a physician about medications, so it is important to have a basic understanding of pharmacology. In addition, the physician will not indicate what polarity the medication is. You'll get the prescription, Iontophoresis with dexamethasone. That's all you'll get. So it's expected that you as the PT know how to do iontophoresis and what the polarity is to be used. The second key consideration is protecting the skin from chemical burns. Typically, burns are not due to the medication, but due to the direct current. And the next slide is going to show why the cathode is typically more problematic than the anode. It's normal to have some mild skin irritation, but you want the least amount of skin irritation possible. You want it to be comfortable, and you want to make sure you want to limit as little resistance as possible. The normal skin irritation might be pink and just kind of like a little tape burn looking sort of thing. And that should resolve in 24 hours. However, the redness and blisters are not normal reactions, and an alternative needs to be considered if you do get some of those signs. So here's what's happening at the skin level in the extracellular fluid. You have water and sodium chloride, and the E-stim of the iontophoresis causes ionization of these substances, which means water and sodium chloride are separated into their individual ions. The anode attracts the negative charged chloride, which combines with hydrogen from the water and forms um, HCl, which is acidic. It's also sclerotic in nature and causes the skin to harden. Under the cathode column, you'll see that the cathode attracts the positive charged sodium and combines it with the OH from water, forming caustic sodium hydroxide, which is alkaline and sclerotic in nature. Oh, I wrote that twice. Sclerolytic in nature. I apologize for my mispronunciation there. Sclerolytic in nature. And this results in the skin softening, and that's what causes tissue breakdown. This process happens no matter which ion is used for treatment. So you're going to get these reactions no matter which medication you're using. It's the ionization occurring at the extracellular fluid from the direct current that is having the effects on the skin. I'm just going to get these all pulled up here. Okay. So it is important to realize which is your active electrode and which is dispersive. If you're using a positive charged medication or a cation, such as lidocaine or the copper sulfate, your active electrode is the anode, because you're going to want to push that medication away from the positive charge. If your medication is negative or an anion, such as dexamethasone, acetic acid, or a salicylate, then your active electrode is the cathode. In other words, your active electrode is the electrode from which the drug is being delivered. You also need to decide on the electrodes that you're going to use. And the size of the electrode is important. And as you can see in this formula, the larger the surface area, the lower the current density, because current density is equal to the current intensity over the surface area. The lower the current density, the less likely there is to be tissue injury. It is recommended that the current density at the cathode be 0.5 milliamps per centimeter squared, and at the anode, 1 milliamp per centimeter squared. Basically, you should use a larger electrode for a negatively charged ion and a smaller electrode for a positively charged ion to make it more comfortable for the patient and decrease your risk of skin irritation. Most electrodes have a buffer, and a buffer is a substance that controls pH by binding to either acidic or basic ions. This decreases the risk of tissue damage. When Ionto first came out, I believe there were buffering solutions that had to be added to the electrodes, but today most commercial electrodes anymore contain buffers to minimize burns. So what is faricable? You can't just put any sort of medication on an electrode and expect to have effective delivery into the skin. First of all, they must have the compound must have a charge, so it has to be an ion. Secondly, it has to be small. It needs to have a molecular weight less than 8,000 Daltons. And it needs to be in solution. You're not putting a whole bunch of a charged substance it is combined usually with water, and then it's ionized, and that's where the splitting of into positive and negative charges occur. Creams do not work, and suspensions do not work. So then under application, you need to think about how you're going to deliver that current. You can use a commercial unit, which is used in the clinic. It looks similar to TENS or a home NMES. These are able to deliver higher amps than home use patches, so wearing time is less, but there's more of a risk of skin irritation with these. There are wearable patches, and they are put on in the clinic and then worn home for up to 24 hours. They are activated by the solution you add to the active electrode, and they have extremely low currents and are typically not sensed by the patient. A newer advancement in the home units is hybrisis. For a few minutes in the clinic, a charge is applied to the patch by a battery that attaches directly to the patch, and a burst of current causes an initial decrease in skin resistance. This initial current is closer to the current from a commercial unit. After a few minutes, the patch then works as a typical home patch. The goal is to more efficiently deliver the medication and decrease the wearing time. There's more of a risk of skin irritation with this treatment, and it hasn't been well researched at this time. So hybrisis, great idea, great concept, but there is a little bit more risk with it. The next few slides show some of the different types of these applications, and we're going to talk more about this in lab as well. Here they are. This is a clinic model, and you'll see on the top, I don't know if I can use a cursor or not to show you. So I'm looking at that top square. That's the top of the unit. I guess it's a rectangle. You have S1 is where your settings for S1. Then you can flip to S2, which is your settings for channel 2. So you can actually use 2 different channels with this. You don't have to, but if you were doing, say, a bilateral carpal tunnel treatment, you could set one arm up on channel 1, one arm up on channel 2, and they could run at the same time that way. The P is for pause. If you need to stop your current or stop your treatment and adjust something, you can. And the R is for you flip it to run, and then it'll just run for the whatever duration it's set for. Below that, you can see those are a sample of the electrodes. The one on the left is the dispersive, and the one on the right is the active electrode. These are the patches, the home use. This is there are 4 different types with this particular brand. There are other brands out there, I assume. You decide based on your wearing time, the dose that you want, the surface area that you're trying to cover, those sorts of things. And then this is a hybrisis, an example of a hybrisis. So I have not used one of these, but it's, like I said, great concept with a little more risk. The batteries are on the that top left picture, and then to the right of that is each individual battery has a charger, that sort of thing. And then down below it, you see the pads, and you can see the place where the battery fits in. You leave the battery there for a while to give that burst of current, and then you take the battery off, send the patient home. All right. Time to talk about dosage. Often I think of dosage as the amount of medication, such as when I give my girls cold medication. I give them a 10 milliliter dose. It's out of our scope of practice to decide how much or what concentration of medication to dispense. This needs to be included in the physician orders and dispensed by a pharmacist. Instead, when we talk about iontophoresis, dosage is in the form of current and duration, and it's written as milliamp minute. Basically, it is, and you'll see the formula on that first bullet point, it's current, which is your milliamps, times your duration, which is the minutes. On clinic units, your current amplitude ranges from 0.1 milliamps up to 4 milliamps. You set the dosage goal, which is typically 40 milliamp minutes to 80 milliamp minutes. You then set the milliamps by turning up the current to what the patient can tolerate. The unit adjusts the time based on the current and the goal. So if the goal is 40 milliamp minute and the patient tolerates 2 milliamps of current, then the treatment time will be 20 minutes. How do you determine dosage? Well, you don't know how much drug is delivered in a given time. Dosage is based on patient tolerance. Typically, on a clinic unit, you start with a 40 milliamp minute goal and try to increase to 80 milliamp minutes in future sessions. The higher the milliamp minutes, the theory is the more of the drug gets through the skin. Skin check during sessions is important because that's how you're going to know patient tolerance. You also need to know longer term reactions, so you're going to talk about your patient, what they should expect after treatment, and what to do if any skin irritation lasts past the 24 hours. With the wearable patch, dosage is different. You don't really get to set any of those parameters like you do on a clinic unit. The battery and the battery is built into the patch. There are no settings. It's based on the patch you choose to use. The electrodes hold a certain amount of medication depending on the size and how the company who makes the patch designs it. Like I said, it has built-in battery, and the medication is placed on the active electrode and saline on the other electrode. Once you put the medication on, the patch is active and you can place it on the patient's skin. You instruct the patient when to take it off and how to inspect the skin, what they should be looking for. Current is delivered at 0.12 to 0.58 milliamps, so it's really not even sensed by the patient. And typically you'll say leave it on for 12 hours, 14 hours, 24 hours. Again, that can all be dependent on the manufacturer of the patch that you're using. So you're going to want to look at specific manufacturer instructions for that. Effective dosage is determined by the following factors: intensity, duration of current flow, concentration of ions in the solution, resistance to flow, the dosage applied, and the depth of penetration. We can adjust, on a clinic unit, we can adjust intensity, duration, and your dosage goal. We can affect resistance to flow by prepping the skin well. We can affect the depth of penetration by spacing the electrodes on the clinic units farther apart. We can't affect the concentration of ions in the solution. That's how however the pharmacist prepares it in response to the doctor's orders. This slide talks about the local effects that occur underneath the electrode. Um, Medicated ions do not traverse all the way to the opposite pole. It's usually a pretty localized penetration, about 1.5 centimeters deep, and it usually stays in that local area for approximately 24 hours. The effectiveness of the medication is decreased if there's more significant skin irritation. You really only want to use one medication at a time with the electrodes. So you're not going to combine multiple types of medication. It's just dexamethasone, it's just acetic acid, those sorts of things. If you space your electrodes a little farther apart, you're going to get deeper penetration. But you could also get some circulatory effects where that medication is absorbed into the blood flow and whisked away that way. So that's important. You don't want your electrodes too far apart either. So some indications. The most common used medication is dexamethasone, and that's an anti-inflammatory. A lot of times you'll see it prescribed for epicondylitis, bursitis, tendonitis. I mentioned carpal tunnel, other tendinitises like patella or Achilles, rheumatoid arthritis. It can be effective for some when in an inflammatory stage of that, or plantar fasciitis. That chart that I showed you earlier has all different possibilities of medications and what they're used for. All right. There's a couple of unique precautions. Let me flip back a second. I apologize. A couple of unique precautions that we need to consider with iontophoresis. As we've already discussed, there can be reactions from the direct current. So you can get a rash under the cathode. You can get that, and that rash can even progress if you have a really severe reaction to an open wound, which is definitely something that you don't want. Use of a buffer, careful skin prep, and increasing the distance between the electrodes can help with this. Also, a larger active electrode can disperse current compared to a smaller electrode, which concentrates the current. Additional things to consider are changes in blood sugar in a person with diabetes, and that would be medication related, so you just want to be cautious with that. And then skin tone as well. There can be different reactions to that. So someone with a darker skin complexion may experience a lightening of the skin under the treating electrode. Contraindications. Most are the same as any other electrical modality, but key ones to really consider: intact skin. You don't want to do this over a wound. This is not a wound care treatment. You also need to think about any skin allergies or sensitivities. You need to, and the other one that's a little bit different is asking if there's a medication allergy. In a perfect world, every patient would remember to tell their physician or pharmacist about any med allergies. However, sometimes you might be the first one to have that mentioned too. It can be missed at times. So we need to be thorough in our initial questioning in order to protect the patient. So let's put this into practice. First, you need to explain the procedure and get informed consent. Tell him that the physician has provided an order for iontophoresis, which involves using a patch to administer some medication through your skin to address whatever concern that you're trying to address. We attach a small battery-operated device to the medication patch to help push it through the skin into the area of concern. And you can say that if you're using a clinic device, or you can say, this patch that I'm going to use has a very slight current that you will not feel to help push the medication through the skin into the area of concern. And then they need to agree or refuse treatment. They have either option. All right. So then you need to prep the skin, and this is essential to protect from burns. You want to document that you inspected the skin before treatment. You want to check sensation, and you're going to clean the area thoroughly. You want to clip any body hair. Again, you do not shave because shaving can really irritate the area. You want to wash with soap and water, and you want it to dry well because you really need that electrode to adhere, again, for safety and effective delivery of the medication. Alcohol can be an irritant, so that is definitely not recommended. You follow the manufacturer's guidelines regarding setup of electrodes. There is a video on Canvas that you can watch, and it goes through it real clearly. Again, we're going to talk about this in lab as well. What you do first is you put your medication on the active electrode, and if you have a dispersive electrode, some need saline, some are just a plain old dispersive electrode. Again, it depends on how they're manufactured. So you put your medication in, you put the active electrode directly over the area you want to treat. You want it to be applied evenly. You don't want air bubbles because that can be a real problem with, again, the skin and tolerating the direct current. If you're using two separate electrodes, you space them out by at least the diameter of the active electrode. Again, that's for patient comfort, but you don't want it too far away either because otherwise the medication could be diluted through the bloodstream. You need to know the polarity of your medication so you know which is the active electrode, and so you set up, and you turn the machine on, and you do your settings, and turn the machine on, and you let it run. And this one, you don't want to do a lot of activity with it during it, because you really want that medication to stay right in the area. Now, you don't, with the home units, you don't limit activity or anything, but you don't want repetitive range of motion exercises while you're doing iontophoresis. Again, we want to keep that medication in the area. After the treatment is over, you're going to observe the skin. Pink is normal. A little bit of color there is normal, but red, swollen, blistering skin is not normal. You also need to instruct the patient on what to watch for any signs of allergic reaction or irritation, and that it should resolve in about 24 hours. And you are going to be, again, documenting what you did, how you set it up, what your parameters were, and how the patient responded to it. You're going to also talk about in your documentation what education you provided, what medication you used, dosage, time frame, those sorts of things. Just a couple more slides here. The adverse reactions that you might see, again, they're due to the direct current. What the lesion will initially look like, pink and raised. Hours later, it may blister, become an open wound. You definitely want to stop treatment at that point in time. If they have really severe reactions, you're just going to need to find another treatment that they can tolerate. And you're probably going to need to talk to the doctor about it and tell the doctor this is how they responded. Do you want to change anything as well, since they're the one who are prescribing the medication. A quick review of literature. One of the clinicians who did this original uh, presentation did a PubMed search, and this is from a search that was done in 2017 using the term iontophoresis with the filters that you can see below for clinical trials and efficacy and dexamethasone, and 8 articles came up. Not a lot for as long as this has been used. A similar search, but for exercise and efficacy, showed over 5,000 articles. So you can just see that more literature is needed to really determine how effective this treatment is. But there are some studies out there, and they're worth taking a look at if this is going to be a treatment of choice for you as you move forward in your career. So let's look at the evidence here. The first one on this slide, there are 200 patients, 6 treatments at 40 milliamps per minute, or 40 milliamp minute, and using dexamethasone for epicondylitis. They had some initial improvement on a visual analog scale, but no difference 1 month out. The next one on here has to do with the hyperhidrosis and using tap water for pediatric patients, and showed that it was an effective treatment, but there really wasn't any controls to say, is this treatment better than other options that are out there. The third one on this slide, the assessment of phonophoresis and iontophoresis in the treatment of carpal tunnel syndrome. This study actually showed that phonophoresis is better than iontophoresis, but there's other research out there that would say phonophoresis is not effective. That said, when you're looking at literature, you do need to look at the size of the study, what they were trying to address, some of those sorts of things. So just to keep that in mind, that there's always literature supporting and negating treatments. This study is interesting in the fact that it compares iontophoresis to a corticosteroid injection. So the iontophoresis was 40 milliamp minutes at 20 minutes 1 time per week, or versus an injection. Both improved, but the injection was more effective, and a weakness in this study was that there was no control. This study talks about how much current is really needed to be effective in depth of penetration of the medication being used. And so you can see method 1 was a current of 4 milliamps times 10 minutes versus 0.1 milliamps times 400 minutes. And there was no significant difference in depth of penetration. Skin temperature was decreased with the low current, and vasoconstriction was increased in the low current, so the medication most likely stayed a little more local. But really there was no difference. So in terms of choosing using a clinic unit versus a home patch unit, both about the same based on this study. And then current intensity in this study was looked at, 1 milliamp versus 2 milliamp, and there was no real difference in current intensity and the amount of medication that stayed in the tissue. So, in other words, you can do what's comfortable for the patient. It may take a little longer at a lower intensity, but really consider patient comfort with this. And then there's this study comparing home units and clinic units. Both units were effective in decreasing pain with sit to stand. They also had a placebo, which had an effect on pain rating. All three groups had an effect on pain rating, but the placebo showed no functional improvement with sit to stand. So, again, both types of treatment were effective. And questions. We're going to be having lab with this on March 7. As I said before, there's a video on Canvas that you can watch to look at how one particular type of patch is applied, and we'll be talking about that more as well. So I'd appreciate it if you could watch that video prior to coming to lab. It's pretty short. And then bring any questions if you want me to review anything. I'm happy to do that when we are together in person. And that is all.